paravertebral space, and the dorsal ramus involvement was posterior to the costotransverse foramen. This is another patient where 30 ml of bupivacaine with contrast dye were injected at T10, and after 90 minutes they made an MRI, and they found sensory loss of between T6, T12 over the anterolateral aspect of the left thoracoabdominal wall, and in the MRI the authors found contrast dye in the paravertebral space, in the intercostal space, and circumferential around the epidural. So there was a clear paravertebral and intercostal signal intensity showing that contrast dye or local anesthetic was in this. In another cadaver study, the authors compared a paravertebral block with an Erector spinae plane block. They injected 20 ml of methylene blue at the level of T4, and they found that after an Erector spinae plane block, only in 60% the injectate spread into the paravertebral space, compared to 100% when they did a paravertebral block. So the spread into the paravertebral space was inconsistent. And many other cadaver studies were done to look for the mechanism of an Erector spinae plane block, and you can see different results. Here you can see what you have seen before, only a dorsal spread and a spread around the dorsal ramus. In this study, they could demonstrate that local anesthetic, this is the light blue color, was found in the paravertebral space. Here also, this was the Schwarzmann study. They found spread of local anesthetics around the spinal cord and in the spinal nerve. In this study also, local anesthetic was found in the paravertebral space and the intercostal space, and also here in this study. But you can see there is a high variability regarding the spread of local anesthetics when you do an Erector spinae plane. What are the mechanisms of action of an Erector spinae plane block? What are the results that we have from cadaver studies? We know that a spread occurs in the dorsal rami in a craniocaudal direction, which will result in a sensorimotor block of the dorsal chest wall. We also have seen an anteromedial spread into the epidural space, which results in a spinal nerve block. We have seen an anterior spread into the paravertebral space with a sympathetic block, and also a laterally spread to the ventral rami, which causes an anterolateral block of the chest abdominal wall. But the open questions that remains are, if we can see dye or contrast medium within the paravertebral space, the intercostal space, or in the epidural space, does this automatically mean a well-working nerve block? I don't know. What is the evidence for the ESP? Reliable and validated is only that the ESP block the dorsal rami. Any additional block of nerves, such as the spinal nerves or the sympathetic nerve, is inconsistent and unpredictable, but it would be very nice if we have a block of these other nerves. What you can always see when you do an Erector spinae plane block is the spread of local anesthetics in a craniocaudal direction. But more important is there an anterior spread of local anesthetics, so that the spinal nerves and the sympathetic trunks are blocked in the paravertebral space. Here, an anatomical picture when the Erector spinae muscles are removed, and you look from the back, and you can see beyond the Erector spinae muscle there are a lot of many deep layers of intrinsic back muscles, as the rotator brevis and longus, levator costarum. And you can see a lot of ligaments, mainly the superior costotransverse ligaments, which is important and which runs from the transverse process to the rib. And in between and the rib, there exits the dorsal ramus, the spinal nerve. And this costotransverse foramen is very important because this might be one of the mechanisms how local anesthetics, this is injected here around the transverse process, enters the spinal nerve or the paravertebral spine. The discrepancy between patients and cadaver is partly based on the fact that the diffusion of local anesthetics in cadavers do not allow to examine the effect of respiratory movement or muscle tension or relaxation and body positioning if we do a block in the lateral position, the prone position, or in the sitting position. We also have comparative studies between ESP blocks and IV opioids for video-assisted thoracoscopic surgeries. And you can see here the fentanyl consumption, rescue analgesics, as well as the pain scores were better in the ESP block group. And this was a comparative study of ESP block and paravertebral block for thoracotomy pain. And you can see here similar results regarding the pain scores and less hypotension, bradycardia in the ESP group. So the conclusion was no difference between both blocks, but a better side effect profile for the ESP. Erector spinae plane block can be also done in the lumbar area. For this area, you need a convex probe because it's a deeper block. You advance the needle to the transverse process and you inject your local anesthetics to block the lumbar nerves of the lumbar plexus. This is an example of the patient in the lateral position. And this is the ultrasound picture that you can expect. It's the same position of the probe that you also use for the lumbar plexus block when you do the so-called trident technique. You can see here the transverse processes, and the needle is advanced through the latissimus dorsi muscle and the erector spine. This is the video of a lumbar erector spinae plane block. You can see the tip of the needle is in contact with the spine, with the transverse process, and then local anesthetic is injected. And it's not so clear, as you have seen it in the thoracic area, that the erector spinae muscle is lifted up. There exist many case reports and case series of the use of the lumbar erector spinae plane block in patients undergoing hip surgery or proximal femur surgeries. We also have a study looking at the combination of lumbar erector spinae plane block and transmuscular quadratus lumborum, or the comparison of lumbar erector spinae plane block and transmuscular quadratus lumborum block for postoperative analgesia in hip and proximal. What are the clinical applications and the conclusion for the practice? The erector spinae plane block is a kind of paraspinal block which is performed more superficial and therefore less risky than a paravertebral block. Indications are all procedures where analgesia is needed from the cervical to the lumbar area. The mode of action is not yet fully understood, and we only have a few randomized controlled studies. If we have somatic and visceral analgesia, depends on if local anesthetics is entering the paravertebral place or not. It's a high volume block, and usually we should use at least 20 ml of local anesthetics, for example 0.375 or 0.5% ropivacaine, or you can use also bupivacaine. The insertion of a catheter is possible. If you use a catheter, you can use ropivacaine 0.2% in a continuous rate of 5 ml per hour. regarding the effectiveness, more comparative studies are needed with the so-called gold standard. These are the thoracic epidurals and the paravertebral block. The complication rate is rather low. Limitations of this block and of the results and studies or case reports we have just right now are the variability and inconsistency of this block. My conclusion is that this block is a block with a high potential, and very important is that the most significant advantage of the ESP block is its simplicity and safety. The final issue of my presentation are the Quadratus lumborum blocks. These are blocks where the local anesthetics is injected in the planes around the Quadratus lumborum muscle. The Quadratus lumborum muscle is a muscle which origins from the 12th rib, the transverse processes of L1 to L4, and the iliac first described as Quadratus lumborum block 1 and 2 by Rafael Blanco already in 2007. A third option, the transmuscular Quadratus lumborum block or Tachia block, was first described by Jens Borglum in 2013. This picture shows you a cross-sectional view of a patient in the lateral position, and it shall explain you where the local anesthetics is injected for the different kind of Quadratus lumborum blocks and how it may work. You can see here the vertebral body. This is the psoas muscle in front of the transverse process. In behind, there's the erector spinae muscle. This black area is the thoracolumbar fascia, the posterior layer, the anterior layer. This is the latissimus dorsi muscle. And here are the abdominal muscles, the obliquus external, internus, and the transverse abdominis. Convex probe is placed in the flank of the patient. And if you do a QL block 1, the local anesthetics is placed lateral from the Quadratus lumborum block. For the QLB2 block, the local anesthetics is placed posterior to the Quadratus lumborum. And if you do a transmuscular block, the naddle is advanced through the Quadratus lumborum and the local anesthetics is placed in front of the local anesthetics. Nowadays, we shouldn't use no longer the nomenclature 1 or 2. It's better to use the nomenclature lateral, posterior, or anterior, because from this nomenclature you can derive the position of the local anesthetics. These are MRI constructions of spread of contrast, and you can see when you compare the lateral with the posterior block, you can see in the posterior block more of the contrast dye is spreading to the spinal nerves and probably also here to the paravertebral space. That means with the posterior block you will have a deeper and more profound block. You will also not also have a somatic, but also we will also find a somatic and visceral. Performing a transmuscular anterior Quadratus lumborum block means that we inject local anesthetics between the Quadratus lumborum and the psoas muscle, and we expect that the local anesthetics will not stay in the lumbar area, but will also flow into the lower thoracic area via the lateral and medial accurate ligaments. In this sagittal image of a cadaver, the yellow line represents the flow of the dye, and you can see that the dye is entering the lower thoracic area. The diaphragma is represented with the blue color, and behind the diaphragma you can see the local anesthetics. On the other hand, we know that after a transmuscular anterior Quadratus lumborum blocks, some nerves of the lumbar plexus and branches of the lumbar plexus are consistently blocked, and this is not the case if you do an lateral or posterior Quadratus lumborum block. Summarizing the data from the cadaver and clinical studies, we can say that after a lateral quadratus lumborum block, the dermatomes are covered from T12 to L1, after a posterior QLB from T9 to T12 L1, and after an anterior QLB from T6 to L3. The paravertebral space is only reached after an posterior or an anterior quadratus lumborum block, and the lumbar nerves or parts of the lumbar nerves are only blocked after an anterior quadratus lumborum block. Different quadratus lumborum blocks, the patient can be placed in a lateral position, and a convex probe is placed in the flank of the patient. What you can expect then is that you can see here the vertebral body and the transverse process. In front of the transverse process, you see the psoas muscle. Top of the transverse process, the quadratus lumborum muscle, and behind of the transverse process, the erector spinae muscle. Lateral from the quadratus lumborum, the latissimus dorsi muscle, and in front, the three muscle layers of the abdominal muscles. If you perform a lateral quadratus lumborum block, the local anesthetics is placed lateral to the quadratus lumborum. For the posterior, the local anesthetic is placed in between of the latissimus dorsi and the quadratus lumborum muscle. And for the anterior quadratus lumborum muscle, the needle goes through the quadratus lumborum and the local anesthetic is injected between the psoas muscle and the quadratus lumborum muscle. You can advance the needle from posterior to anterior or from anterior to posterior. Here, the lateral QLB block, you identify the three muscle layer, external, internal, and transverse abdominis muscle, and the quadratus lumborum, and the needle is advanced anterolateral. You can see here in front of the quadratus lumborum, the local anesthetics, the tip of the needle is placed, and the local anesthetic is injected. Here again, the typical picture you can see for the transmuscular approach. You advance the needle from posterior to anterior, and until you are in the right plane between the psoas muscle and the quadratus. Here the needle is advanced. Now we are in the right plane. You can see the distinction of both muscles. Here you can see the spreading of the local anesthetics between the both muscles. For the posterior quadratus lumborum muscle, you have the same picture. You see the vertebral body, psoas muscle, erector spinae, latissimus dorsi, quadratus lumborum, and the needle is advanced posterior to the quadratus lumborum in the plane between dorsi and quadratus lumborum. In this video, a needle tip cracking technology is used to identify the tip of the. When you are in the right plane, you inject the local anesthetic, and you see the distension of the both muscles, the latissimus dorsi and the quadratus lumborum. We also have some studies here for laparoscopic surgery. The comparison of the posterior quadratus lumborum and the lateral transverse abdominis plane block, and you could see the time until first rescue analgesia was used was much more longer for the QLB for the posterior quadratus lumborum compared to the lateral tab, and also you can see here that the thoracic dermatomes are more often blocked with the quadratus block. Here, the effectiveness of the posterior quadratus lumborum for cesarean section compared to IV opioids, and you can see with the posterior quadratus lumborum block, the morphine consumption was reduced and the patient had a lower pain score. A comparative study of the posterior quadratus lumborum with the lateral transverse abdominis plane block for cesarean delivery confirms that the Quadratus lumborum block was more effective in reducing morphine consumption and demands up to 48 hours post-operatively. There's many other case reports or studies for different kind of operations. You can see here for total hip arthroplasty, the effectiveness of transmuscular quadratus lumborum block, again transmuscular quadratus lumborum block for iliac crest bone harvesting, for femoral bypass graft placement, What is the evidence for the QLB techniques? Indications for the lateral QLB are lower abdominal surgeries, for the posterior QLB lower and upper abdominal surgeries, for the anterior quadratus lumborum lower upper abdominal surgeries and hip surgery, which dose should be used, at least 20 ml of ropivacaine, for example, 0.375%, or bupivacaine. Catheter are possible. You can use a continuous rate of 5 ml per hour of 0.2 ropivacaine. What is the effectiveness? Comparative study are lacking. What are the risks and what are the complications? We don't know exactly. Let me summarize the significance of pec serratus, erector spinae plane, or quadratus lumborum blocks in regional anesthesia. First of all these blocks are interfacial blocks. That means these are not classical nerve blocks. The technique of choice when you're doing these blocks is ultrasound-guided technique. If you have an opiate-free or opiate-saving technique, depends on if you block only somatic or if you block somatic and visceral fibers. Effectiveness and spread of local anesthetic, we can say there's a lack of consistency. All these blocks are unpredictable, and even if we are with the needle tip in the right plane and we see that the local anesthetics is spreading in the interfacial plane between two muscles, we cannot say this block will work 100% or not. Effectiveness, there is a validation, is depending. What are the indications for these blocks? Major procedures, when more effective and riskier procedures are contraindicated, such as thoracic epidurals or paravertebral block due to anticoagulated patients, and also minor procedures when more effective or riskier procedures are not indicated. The complications rate is rare. Serious complications are really rare. And in anticoagulated patients, what shall we do with these kind of blocks? We have not yet recommendations so far, but to my opinion, we can follow a more liberal regimen than uraxial blocks when we do these kind of blocks. Thank you very much.
Hello. Back again.
Hi.
Thank you.
Thank you, Professor Kessler, for your insightful presentation. So let's move on to next Q&A section, which probably takes 25 minutes. I've seen many audience to ask questions in here, but due to time limitation, I will choose some of them. So the first question is from a doctor. He is asking that in our clinical practice, we found sometimes it's difficult to provide perfect or acceptable analgesia for patients with pelvic fractures, such as fracture of ilium, pelvis, sacrum, and acetabulum. It's quite difficult to pronounce a very professional vocabulary for me. It seems very difficult to cover all of the nerves innervating this area with a single block. So how is your opinion?
This is a very good question. I think it's difficult to answer. If you have a pelvic fracture or a difficult pelvic fracture, you have to block the lumbar sacral plexus. That means with a single peripheral nerve block, you cannot achieve a whole analgesia-free patient. you have to do at least 2 blocks. A lumbar, you have to block the lumbar plexus, and you have to block the sacral plexus. Of course, you can do it with one injection. This is an epidural. You can do an epidural block in these patients, but an epidural to place in patients with pelvic fracture is very difficult, because already the positioning of the patient to bring the patient in a lateral position after a pelvic fracture will be difficult. If you have a bilateral pelvic fracture, it's nearly impossible. If you have a unilateral pelvic fracture, you can turn the patient on the not fractured side, and then you can do your epidural, and you can place a catheter. But you also have to keep in mind the epidural may be a little bit contraindicated, because patients with pelvic fracture need a lot of blood, they need a lot of transfusions, and they are at a high risk of coagulation disorders postoperatively. And then, if you have done a neuraxial block like an epidural, or if you have placed an epidural catheter, there is a higher risk of an epidural hematoma. Therefore, if it's possible, you should do some kind of peripheral nerve blocks. As I mentioned before, you have to do, for a complete free analgesic patient, you have to do 2 blocks. Maybe you can do a lumbar plexus block. So you have to place the patient on the lateral side, and you can combine it with a high, very proximal sciatic nerve block. This will work, maybe. But indeed, it's a difficult decision. And in my practice, we sometimes also combine a lumbar plexus block, which covers only the lumbar area, with a anterior quadratus lumborum block, because with this block, you also cover the lower thoracic nerves, and these are sometimes necessary, because when you have the fractures at the level of the iliac crest, maybe a pure lumbar plexus block will not be sufficient.
Excellent, very detailed. Yeah. So the second question for you is, as we know, Truncal blocks are very effective in post-operative anesthesia. I wonder if it can be used as a main anesthetic method during surgery, like spine anesthesia or epidural anesthesia.
As you have seen in my presentation, most of the so-called abdominal thoracic truncal blocks are blocks which provide somatic analgesia. That means you can block the nerve for the skin, maybe for the bone also, but not for the deeper organs. And therefore, these are only suitable for post-operative analgesia. What you can do with these blocks, for example, iliac crest bonus harvesting. But if you want to use these blocks as a sole anesthetic technique without general anesthesia, you must provide with these blocks also, in addition to the somatic analgesia, also a visceral analgesia. And this can be nicely done only with the neuraxial blockades. But you can use also an erector spinae plane block, and maybe the posterior or anterior quadratus lumborum block. And we have a very few data for the thoracic erector spinae plane block using in patients undergoing radioscopic thoracoscopic surgery, that this can be used as a sole technique. But it's always a matter, you cannot be sure if this block will work. And this is also common to all these blocks. Even when you are with your tip of the needle in the right plane, and you inject your local anesthetics, and you can see the distension of the space between 2 muscles, so you are correctly in the right plane. You cannot be sure that this block will work 100%. This is completely different if you do an ultrasound-guided nerve block. When you see the nerve, you inject your local anesthetics, the local anesthetic is flowing around the nerve. You can say this block or this nerve is blocked by 100%. This is completely different with the interfacial plane blocks. This you have to keep in mind. So for me, my preference would be that you use these blocks more or less only for post-operative analgesia, not as a sole anesthesia technique.
Okay, very good. So the third question is also from the audience. he mentioned that Truncal blocks are often very good for superficial pain, but sometimes are poor